Hey, everybody. What am I doing wrong here?
See is
Oh, there we go.
find Ronnie. Hi everyone.
Hi, Ronson. Hi, everyone.
Good afternoon. And people can start just putting their names, titles, organization in the chat. That'd be great. Thanks. Okay, it's 3:02. Let me see here. Still don't see Ronnie here, so I might have to lead the meeting. Okay, well, thanks everyone for joining our April Homeless Task Force meeting. We have some good presenters here today on the latest updates in homeless services and housing. Um, let's see, let's start with Grace on, it's Grace here, Grace Wolman, or someone from the coalition.
I don't see them on.
No, okay. All right. Um, let's see, Grace. I guess just one update from the coalition. They are hosting an event next week, a Connect Day. This is in conjunction with SD2. Let me just pull up some information on that. Hold on one second. It's the Harbor Gateway Connect Day. And let me share my screen. So yeah, if you guys can see that, hope you all can attend. Um, this will be for the first one of I think 3 or 4 of these that we'll be doing in collaboration with the coalition. So this April 23rd at 10 a.m. It is going to be 11500 Figueroa Street, right at the Metro Green Line stop. So yeah, hope you guys can all come out. There'll be music and food, so it should be a great event. We used to do these more regularly before the pandemic, and so I think we're trying to get back to that, so that we can provide resources for our unhoused neighbors. Cool. And so then just moving on, we can maybe come back to Grace if she joins us. We have a presentation today, very important presentation about county services. And Yvonne Golub, our consultant from here, will be presenting. Yvonne, are you there? Let's see. Where is Yvonne? I don't see her. Let me,
I think some people might have difficult accessing the link. Let me give them a call.
okay. Yeah.
Ronson, I'm here. This is Grace.
Oh, Grace, hey. I gave them an update about the Connect Day, but I
Yeah,
don't know if you had any other updates.
no, and if thank you for the update. If you have any questions, just email us, and if you want to support the event or come out, please let us know.
Okay, great. All right. Well, so I feel like Kelly, like, so our case managers, right? They do like almost everything. They do everything from helping people gain their documents, connecting them with legal services, making housing referrals. But one of the things our case managers do is they also work on their health, like the health care of the person that's experiencing homelessness. They take them to doctor's appointments, they sign it up for medical insurance. And so there's like a whole list of things our case managers do on the healthcare side of the world. And what I wanted Yvonne to present is that they don't have to do that. Like there are healthcare case managers that can take over, and they're called enhanced care managers, ECMs. And what we want to do is have more of our case managers connect to ECMs so that they can take over the healthcare stuff, so that the case managers don't have to do that. Um, and see if, let's see, I have her slides, but if she's not on, I guess I'll just go ahead and present them.
Give her a moment.
Okay. Okay. Well, let me get her slides up.
Bronson, do you want to go back to Grace? I think she's on.
Oh yeah, no, Grace didn't have any other updates than the one I presented. So yeah, let me see. One second. Okay, everyone see that? These are Yvonne's slides. Um, yeah, so the first slide we were just talking about what enhanced care management is. So it's a higher level of personalized care.
She's on Ronson. She's there.
Pardon?
Yvonne is here from Hero, isn't she? She's right there.
Oh,
Hi,
Yvonne's here?
can
Oh,
you
hi.
hear me? Can you see me?
Yes.
Yeah.
Hi, thank you. I apologize. Thank you, Addie, for your support. I appreciate it. And thank you, Ronson.
Yeah.
Hi.
So I just gave everyone kind of like an overview of why we're talking about this. Can you guys still see the slides?
No.
Okay. Oh, here we go. Can you see it now?
Yep, they're up.
Okay, great. Um, I'll just leave it there. But yeah, so you know, I just was telling them how like ECMs, they're kind of the case managers on everything healthcare related. They can make referral. Oh, why don't you just take over and talk about this
Yes.
slide?
Thanks, Ronson. Thanks,
Yeah.
Addie. Thanks, Jackie. So, what is enhanced care management? As Ronson said, enhanced care management is kind of the quarterback of the Medi-Cal side of navigation for our community members in SPA 8. So, what does that mean to you? That means that you have your own personalized case manager to support and help you navigate if that community member has Medi-Cal under the state of California, and for us, it's in Los Angeles County. So they can help you with medication management, transportation to and from any medical appointments. That includes community resource centers if you're getting help with medical navigation. They can meet you on the street. They can meet you in the resource centers or in the doctor's offices. They can meet you online if you have asthma remediation and you need supports around that. They can do residential modification if you need a specialized bed, if you need a commode lift, if you need a assistance pole. So they'll do home modification if needed. If you have a special diet, maybe you're diabetic and you need a special diet, they will help you with that, as well as some pregnancy and postpartum up to 12 months medically tailored meals. Next, slide 3. So what is the criteria? What would be the criteria to support you in receiving enhanced care management? Do you have Medi-Cal in the state of California in Los Angeles County? Is there a social mental health criteria? And that needs to be documented with Department of Mental Health, with drug and alcohol addiction. Is there chronic health issues, either physically, mentally, or developmentally, or an intellectual disability? Are you pregnant? Are you up to 12 months postpartum? Are you unhoused as defined by HUD, which would be are you at risk of being unhoused? Are you unhoused? Are you in an environment that is not habitable for a human? Are you fleeing domestic violence? Are you at risk of being unhoused within 14 days? Are you a transitional population? And so transitional population means, are you coming out of a skilled nursing facility? Are you coming out of hospitalization? Are you coming out of a 5150 hold? Have you been revolving in that 5150 mental health hold over and over, or drug and alcohol addiction? Or has it been a reoccurrence that you're going in and out of urgent cares or skilled nursing facilities? Post-hospitalization, are you in foster care in and out? Next slide. And who are these populations that would qualify under that criteria? Are you experiencing homelessness? Are you an adult? Are you an unaccompanied youth? Are you a child? Are you an adult, youth, or child who has been in and out of the emergency department or urgent care? Are you an adult, youth, or child who has been in and out of substance abuse and treatment? Have you been involved in the child welfare system? Are you transitioning from incarceration? Are you an adult living in community and at risk for long-term institutionalization? And are you in a nursing facility, or are you in transitioning back into the community? All of these things on the medical side, when I'm looking at it, You're bringing this information to me or our enhanced care management navigators in SPA 8, and I'm trusting and verifying, trusting and verifying, trusting and verifying all of this information so I can document it all, bring it all together, and then present it to the plans in LA County in California under the umbrella of Medi-Cal. Next slide, please. So under that umbrella of of enhanced care management is another umbrella called community supports. What is community supports? So once you're signed up to enhanced care management, you can access community supports by your navigator helping you in ECM. That means that you have the housing trio. Now I'm going to expand on housing trio a little bit. What does that mean for you? The housing trio is long term, think long term case management for housing. Community supports in the shorter term is transitional rent. So under community supports, we're doing housing transition and navigational services, which is supported by my colleague Matthew Brennan in Hero, as well as Kevin Numera, who helps with housing and listing and navigation support services for us under the COG. Housing deposits, we're looking at assisting with housing security deposits, setup fees, last month's rent, any necessary things to keep your residents comfortable, air conditioning, heating, a hospital bed if needed to keep the home safe for move-in, utilities. Housing tenancy and sustaining services, which is where Matthew again would come in. And Matthew's kind of that liaison after everything is verified to be able to communicate with a landlord to keep that tenancy stable and secure for coordination. And so we're preventing eviction. We're preventing the breakage in the link where somebody may be in the rears or at a risk of loss of losing their stability in their housing. And so we are a bridge for that. Now, the county was given orders, the new program HSH under LASA, under our Board of Supervisors, they were given their marching orders. And they weren't given strong navigation necessarily on how to implement that programming. And so we were hoping to have that done by March. And it's a lot of work. It's a lot of navigation, and everything now is verified. We're not just cutting checks for people's housing. We have to have a sustainability model. And we're working with our community members to make this written, documented, long-term progress within case management to ensure the success of our community members. And so they're working on building out that framework. Right now, we do have transitional rent, which will pay someone's rent up to 6 months under the community supports of enhanced care management under Medi-Cal, but that is short term. So that transitional rent is for members who are experiencing or at risk of homelessness. How would you receive these benefits? How would you receive this support? Next slide, please. Thank you. So you can go to Enhanced Care Management Support Services through our Beach Cities Health District in Redondo Beach. The address is there and the phone numbers are here. You can access Lutheran Social Services, Magali or Wendy in Long Beach, who are very helpful and very knowledgeable. You can utilize the community resource centers in Service Planning Area 8, which is one of my preferences. I like to utilize the community resource centers because they are run by LA Care, which is Los Angeles Medi-Cal Group and Blue Shield Promise Medi-Cal Group health plan in Los Angeles County. And we have 3 community resource centers in Service Planning Area 8, where 100% of those resources are free for any case navigation. Anybody can walk in and ask for ECM support and case management support. And they can do it by phone as well, as long as they have all their documentation. And there is the Family Promise Center in the South Bay in Torrance. Their address and phone number is there as well. And they can all help with enhanced care management. What do you need to have to start that process with your community member? What are we looking for? We need first name, last name, date of birth. If they are not signed up for a health plan under Medi-Cal, we will need a social security number. If they have had Medi-Cal before, we will need that number, that it's called a CIN number. We will need that SIN number, and we need a phone number and a way to contact that community member. My name is Yvonne. My information is on slide number 1. Are there any questions that I can help with?
I just want to clarify too. So right now, if you were to get connected to a community supports person, the top 3 of the housing trio are available for folks, including the housing deposits. And so this is a great tool for people to use for people with the medical needs that need the first and last month's rent. The transitional rent piece of it, they were supposed to have this launched in January. The county has taken over the responsibility of this piece. Unfortunately, there has been a delay and they're having problems setting up this program. Again, this is a state program, but it's administered by the county. And so it looks like they're not going to be able to figure it out till maybe the end of the year, which is disappointing, but we'll continue to work with them to try to get this up and running. So this actually isn't available right now, although it's supposed to be. If you go to some other counties, it might actually be up and running. The alternative also is that we have our La Casa funds for prevention that we could use. Although the cost of funds cannot be used for homeless, it can be used for prevention. And then we starting, next fiscal year, we'll have another tranche of time limited subsidies that we can use for folks. So just want to clarify those 2 points.
Thank you, Ronson. We do have a couple of programs out there in Service Planning Area 8 under Medi-Cal that are supporting our community members for up to 6 months of placement in drug and alcohol rehabilitation and some shelter housing. And I'm happy to help anybody navigate around that and find that information in Service Planning Area 8. Thank you, Ronson.
Great. Hey, Ramon.
Hey, good afternoon, everyone. Thank you, Yvonne, for your presentation.
Oh, Ramon, can you speak up a little bit? It's hard to hear.
Yeah, good afternoon, everyone. Thank you, Yvonne, for your presentation. I just have a question. I saw that, are there case managers at the Beach Cities Health District? If so, like how many?
David's here. David, do you want to answer that question?
Yeah, currently we have 5 care managers who are all social workers, who are all trained as social workers. We will, I just put a comment in the chat. We're not live yet for ECM. We're still onboarding. And there's been some delays, but we anticipate mid-May to go live. Yvonne, I'll be in touch with that. So we have 5 care managers, and there is an anticipated hiring plan to bring on more care managers as needed. Right now, we're currently going to serve the 3 beach cities for ECM. Eventually, there might be a discussion with the board about expanding out to other areas within SPA 8. So we just have to trickle that and grow responsibly. So there is a plan to bring on more care managers if there is explosive growth with ECM. I hope I answered your question.
You did, thank you. And then the qualifications for people need to be homeless on the streets? Do they
No,
qualify?
it's the category they're called populations of focus, which Yvonne covered earlier in her presentation. So beach cities, we're working with a specific type of population of focus. So at the district, and we do have an alcove program for youth. So they're considering anything that is listed for children. But we basically are individuals experiencing homelessness, adult high utilizers, adult with serious mental illness, individuals transitioning from incarceration, individuals at risk for institutionalization and eligible for long-term care services, nursing facility residents who want to transition to the community, adults experiencing homelessness, adults and families experiencing homelessness, individuals at risk for increased hospitalization and emergency department utilization, adults with serious mental illness, and adults with a birth equity population focus. So those are the categories that we will be working with, and then ALCO will be working with populations of focus for the children and youth. When we are close to going live, I'll make sure there'll be some type of flyer or something that goes out in this group or to Yvonne explaining exactly the population of focuses that we're working on. And we're currently working with a few of the health plans. We don't work with all of them. So that was good information to hear about LA Care and the service centers.
Yeah, I think the populations of focus is slide 4, I think, or maybe 2. But Ramon, what they're looking at is the literal definition of being unhoused by HUD,
Okay.
which is at risk of not habitable for human safety, or at risk of within 14 days of being unhoused. And the ECM managers can meet a community member on the street where they are, or over the phone, or have them come into a resource center like Beach Cities or the community centers or any of the ones listed in the resources at the end of the PowerPoint.
One more question. It might be whatever, but so let's just say I work with people who are HIV positive. How would they benefit from this program, and how would I connect them with you guys?
Yes, absolutely. You can reach out to me. My information is on slide number 1. My email address is yvonne@herocommunityservices.org, and I can help you navigate that.
Thank you.
You're welcome.
And just want to also add, normally the other way to access these services is through the health insurance card and calling the
Yep.
managed care provider. What we're providing here is kind of a way to kind of get around that and go directly to the service providers. So thanks, Yvonne, for putting this together.
Absolutely. And that's one of the things that we're looking at when we're verifying a community member that I always ask for is, do they have their health insurance card? And 90% of the time, maybe higher, probably 97% of the time, they say, yeah, I have Medi-Cal. Well, okay, super. Everybody has Medi-Cal almost. A lot of people have Medi-Cal, but under Medi-Cal umbrella are all of these health plans. There's 6 major health plans in Los Angeles County. So is it LA Care? Is it HealthNet? Is it Blue Shield Promise? So that's what we're looking for, is that card and the phone number on the back of that card. And we really encourage community members to learn how to drive that phone number on the back of their health insurance card to call, ask for social services, ask for navigation. And Ronson is absolutely right. That's what we're doing here, is we're helping our outreach workers, our community-based organizations, you all drive that and get a more personalized, high-touch experience to help you drive that.
Okay, any more questions? Okay,
I
well, thanks,
have
Yvonne.
a question.
Oh,
So I supported a student of mine. I'm from Kelsey Dominguez Hills. I'm a care coordinator. We did contact in the back of the car with their member service card, and we did contact for Cal Aim support. They did do the whole like questionnaire. They were notified that they were going to be getting contacted within, I want to say 2 to 3 business days. It was about a week since I followed up with the student, and there hadn't been no follow up. So not sure. I encourage the student to call once again just to get an update. So what would be like, what is the time frame for this individual after they contact to get a call back and start the process of getting the support for enhanced case management?
It's a couple of days. They're verifying all of the documents as well. And then they'll reach out within, 48 hours, 72 hours. We really want to make sure many times that phone number may not always come up with the name of the health plan. So sometimes people don't pick it up, but they are trying to reach out to them. And
so
many times they would do 3 times a reach out plus a letter to a place of residence, but that's very difficult with many of our populations.
Liliana, nice to meet you, by the way. Let us know how it goes because this is relatively new and we want to what's weird about this to me is that these programs sit outside of our homelessness continuum of care. And so like I encourage also everyone else that has experience with trying to get these medical services to document that and like let us know if you're having any
Yeah.
difficulties because what we want to do is also report any issues to our state friends. The other thing that we've also noticed, and let us know if this happens to your client, is that they will be referred to someone far away. So like the
Mm,
case manager is like in Whittier or I think Yvonne's even seen someone in Los Angeles being referred to a case manager in San Diego, which is really
yep.
weird.
For
Um,
housing,
right,
bonkers,
yeah.
bonkers.
So that happens to you, let us know because we obviously don't want that. We have plenty of great ECMs here in the South Bay and who are familiar with South Bay resources. And so we don't understand why people are getting referred to places so far away.
We're working on that on the back end here to try and make that better, but it is happening. And so, like Ronson said, the more you let us know, the more it helps us navigate because, somebody in San Diego is not going to know Compton, CSUDH, Carson, navigation for housing. And we respect and understand that CSUDH absolutely has an unhoused student population there, and we really want to support them. And please feel free to reach out to me anytime. And our own COG, Kevin Umara, does a great job for listing housing resources right here in Service Planning Area 8 that are affordable. I give them out to case managers all the time.
How long did you say it's been?
It's been about the last time I met with the student was about a week ago. So it was a week. We called and then we checked in a week and then they hadn't gotten anything back. I made sure to make sure that they checked their voicemail. They hadn't received anything. So we
Mhm.
tried calling, but it was a wait. So I encouraged them to call back during their own time. So I will be checking back in with them this week to kind of figure out if there's any updates on their end, but I'll follow up.
And do you know what health plan it is?
Not on top of my mind, no.
Okay. Yeah, that just if you can do me a favor, just send us an email. That would be great. I'll put our emails in the chat
Will
And
do, thank
sometimes
you.
we
if you
have,
figure out what the who the health plan is.
yeah.
Yeah.
Yep. And that's one more reason to consider also thinking about the community resource centers is because they're directly on that campus. Like, do they have LA Care? Well, you can walk directly into an LA Care Community Resource Center or Blue Shield Community Resource Center. And sometimes our own ECM, like listed on the slides, we have personal relationships with some of those navigators, and so we might be able to assist you. So please do reach out and let us know how we can support you. And do you still have the Senior Resource Center on campus at CSUDH?
I want to say we do. I will definitely make sure to follow up on that as well.
Please do. We know you've got seniors on campus and we want to help.
Thank you.
Thank you.
Okay. Council member Uphoff, since you're here, would you like to chair the meeting? I know it's kind of since Council member Tanaka isn't available.
No, you're doing a great job, Ron. So just keep going.
Okay. Well, you, Council member Montero.
Hi, Bronson. No, you go ahead. Ross,
Okay.
you're doing great.
I just wanted to check.
Thank you.
We appreciate the offer though.
Yeah, it's best for us to listen.
Okay.
Yeah.
All right. So then moving on to the next topic, we have George Yakub. Am I saying that right?
Yeah, you got it.
Great. Thanks. Welcome, George. I've been actually been waiting for this presentation for a while now.
Have you?
From Brain Health. You guys are kind of a new provider to us. And so would love to learn more about you all and what you are doing here in Spot 8, and as it relates to mental health services. So
Right.
yeah, why don't you take it away?
Yeah. Thank you everyone for having us, Ronson. We really appreciate it. What I'll do is I'll introduce our mobile crisis team, okay, and then I'll hand it over to my other colleague who'll talk to you guys about brain health as a whole, as an organization, okay? Now, Ronson, am I able to share my screen so I can show you guys a PowerPoint?
Yeah, you should be able to. Let me know if you
Okay.
can.
All right. All right, here we are. Can you guys see my screen? All right, amazing. So, hi everyone. My name is George. George Yakub. I work as a psych and family nurse practitioner, and I'm currently the clinical operations manager for our mobile crisis team. Brain Health set out to collaborate with the Department of Mental Health, LA County, to offer the MCOT services. So I think what was happening before is the Department of Mental Health, they have these field teams, PMRT, right? I'm sure you guys have seen them and the pet teams. They were covering a majority of the day, okay, but they didn't have coverage at night and on the weekends, okay? And this was around 2021, 2022. So they set out, to establish collaborative partnerships with several organizations to offer this mobile crisis outreach team. Okay, so that's essentially what we do in Service Area 8. Brain Health has also been contracted to offer services in Service Area 7, okay, which is more East LA. Okay, and so I'll go ahead and talk to you guys about the program, okay? And then I also have one of our clinicians here, Bradley Sasada, who does a great job with our patients and clients out in the field, okay? And I'll have him kind of briefly share a little bit of his own personal experience and philosophies. Okay. Okay, so what is MCOT? Stands for Mobile Crisis Outreach Team. We're essentially synonymous with what PMRT has, which is a psychiatric mobile response team. Okay. We're obviously a mobile first type team. Okay. We're dispatched throughout the county. Okay. And what we do is we're able to respond to clients who are in any given location. I could tell you some pretty random spots where our teams ended up going. Okay, but as far as since here it's a homeless outreach team that you have here, maybe I can specify it for, people that are homeless or that are unhoused, but encampments we'll go to. You will meet people in like parks in the middle of the night. Sometimes, I've gotten a call for cemetery, right? Shelters, of course. We do local emergencies. Okay, sometimes that particular hospital doesn't have someone who's LPS trained, and so they'll call the Department of Mental Health, and we'll be dispatched to the ER, do an evaluation, and determine if this person meets criteria for a hold. Okay, and then also we do schools, and obviously people's homes. So our teams are composed of two people, okay, one clinician and then one mental health worker. Our clinicians range in discipline anywhere between RNs, LCSWs,
This is
MFTs,
David.
MT, sorry, MDs,
Yeah, it's
okay,
the same.
and psych NPs. Okay. And then they're paired up with a mental health worker, and that's usually somebody with lived life experience, somebody that can, offer support to the clinician while they do their assessments and determine risk, while also maintaining a somewhat safe environment and also helping the clinician establish rapport, okay, with whoever we're dealing with at the time. Okay. And as I mentioned earlier, we get tons of calls in service area 8, okay, and also in service area 7. Okay, core philosophy, and this applies to the whole company as well. Okay, but trauma-informed care. A lot of our clinicians, obviously they focus on trauma, but they've had their fair share of experiences in the past. Okay, and it allows them to be, a little more relatable. Okay, and so trauma is one of our very big focuses. All of our clinicians and team members are humble, and you'll notice that when they're talking with whomever they're talking with, especially this unhoused population. Okay, and obviously we maintain dignity in these people, right? These people, I would argue, need it the most, right? So one thing about us, like PMRT, is we have the ability, all of our clinicians, regardless of discipline, are able to write 5150 holds, right? As you guys are aware, um, a lot of times, with the unhoused population, grave disability is a primary focus, okay? And we take our time, we do a full, thorough assessment, okay? And we determine if they meet criteria. And if they meet criteria, what we do is we manage to get them to a designated LPS facility, okay? And if that doesn't turn out, okay, the way we wanted it to, we can't transfer them for whatever reason. I'll talk about that in a minute. We connect them with the right resources. Okay. And obviously, if they meet criteria for other things, such as, danger to others, danger to self, we go ahead and assess for that. Okay. And then get them the help that they need.
I do want to add real quick,
Yeah,
George.
sure.
Gravely disabled has changed within this past year.
Right.
As of January 1st, it's not only if they're able to provide food, clothing, and shelter,
Mhm.
but also substance abuse has become more frequent, and they
Yes.
actually added it to the 5150 hold so that you could meet criteria for abusing
Yeah.
drugs
Yeah,
without
absolutely.
being
Absolutely.
used.
The SB43 you're referring to.
Yes.
Yeah. So all of our clinicians have had that updated training. Oops, I'm sorry. Okay, and definitely assess for that. Okay. Okay. So challenges that we faced. So I'm sure a lot of you might know this, some don't. But sometimes when this person does meet criteria, again, we're a hands-off team and we can't really, force anybody to go on a gurney. And a lot of times, it's in the name, it's an involuntary hold. People are just not, um, they're not compliant and they don't want to go. Okay. And so we have to rely on other community members, other agencies, right, that can help us facilitate transportation. Okay. And so what we do is we try to work alongside law enforcement and hope that they can help us, with facilitating transportation, them essentially getting on the gurney. Okay. And so sometimes this can be a dilemma that we face. And so what we've done is we've changed our approach. Okay. And we created new we'll call them workflows, right? And so we're able to use specific terms that maybe the law enforcement officer can relate to, right? And then really communicating the imminent danger that this person might face if we leave, okay, and don't get them the help that they need. Okay. And so, slowly but surely, if law enforcement has been a lot more, cooperative with us, and we understand that, we might not be priority on their call list. Obviously, there's emergencies, okay, but we definitely work with them, okay, and we try to establish a good, good strong relationship while we're out in the field. Okay, so I want to call our secret weapon. Okay, so a lot of our clinicians and staff members are very relatable. Okay, They really connect with the person, for who they really are, and try to avoid using obviously terminology that might not be familiar with. Okay, and there's a sense of, I want to say intimacy with the situation. Also, we have some time to spend with them as opposed to maybe other settings or situations where the clinician or whomever might not have that time. Okay, so we're able to make sure that we offer a very specific approach to them. Um, a lot of times, like I mentioned to you, like some people don't want to, follow through with transportation. Well, that's where we kind of take the time, okay? We explain to them the purpose of what we're doing, okay? Explain to them the benefits of what we're doing, okay? And we try to persuade them, and obviously in an honest way, okay? And I think we found that that clinicians, okay, maintaining like almost like an exaggerated level of honesty with people that are in a crisis goes a long way, and yeah, just to maintain that trust. Okay, so a lot of times we're able to turn a no into a yes. Okay. Okay, so I'm sure you guys are familiar with the home team, right? Right. So, so our MCOT is obviously not not a home team. We don't offer those types of services. We are a triage team, but what our clinicians know to do is to, make that referral to a home team, somebody that meets the criteria for home. Okay. And so we essentially we show up to the call, we de-escalate, stabilize, okay, and then obviously link them up with the right people, okay, and or send them to a psych facility. Okay, so this is essentially our workflow from start to finish. Okay, so anybody from the public can call a Department of Mental Health, DMH access, right? So you call, okay, our access operators. What we'll do is they'll dispatch the call to us. Okay, they'll tell us exactly where it is. Okay, and details of the call, including the person's history. Okay, if we've seen them before. And so what we do is we go out to the call. Okay, both team members, a clinician and a peer. Okay, and what we do is we meet with the requester. A lot of times, requests are made by family members, spouses, teachers, counselors, administration from a shelter, right? Or even just a good Samaritan. A lot of people just, they will see somebody who's, in the middle of an intersection and they're concerned about them. And so what they do is they call access, they try to give us the exact location, and our team will go out and talk with them. Okay. So once we gather collateral, we then speak with the client. Okay. And then we do a risk assessment, determine the risk. Okay. After that, essentially, we, coordinate transportation, de-escalate, offer mental health linkage, right? We can connect them with an outpatient clinic if they need to. We can try to make a referral to, Department of Social Services, okay, ECM, okay, and then if they don't have insurance, okay, if they're indigent, what we'll do is we'll make sure that they're able to be transported to local county ER, okay, and we'll essentially map them out. Most of the time when we're writing a hold and sending them to a psych facility, we try to send them to the crisis stabilization unit. Okay, I think that has the best outcome per se. And we use crisis stabilization units for others compared to the unhoused population. That one is a little different. Okay, so what are the goals of MCOT? Okay, provide rapid field-based crisis, okay, responses. And again, this ranges from location, right? And we engage in individuals from different backgrounds, different age groups. We see clients as young as 6 years old, and I've seen a client as old as 102. Okay. Our teams are trained at essentially de-escalating, okay, focusing a lot on family. So what we're realizing is his family takes the big burden of all this, right? And so what we do is, we focus and address the concerns of the client, okay, but we place a lot of emphasis on family members, okay, and better equip them on how to, handle their, loved one. right? And so we teach them, communication techniques, right? We can also offer them and make a referral for group therapy if they need to, family therapy, right? We provide psychoeducation on certain conditions, right, that they may not be familiar with, okay? And again, our clinicians and peers take the time, right? And they make sure that before they leave, okay, that the family has a higher sense of confidence, okay, and will know essentially what to do, the next time there is a mental health crisis in the field. Okay. We try to reduce law enforcement involvement, but we will call upon them when we absolutely need them. And what we also try to do is we try to avoid sending our patients, our clients to local ERs, right? So we don't overwhelm the ER system, right? We will only send them to an ER, like I mentioned, if they don't have insurance. Okay. But they'll just go to a county ER. Okay. So
If they're medically compromised as well, we do have to take them to an ER just to get the get us basically checked out to make sure that they're equipped to go to a psychiatric hospital, because psychiatric hospitals cannot take care of patients that have a medical emergency
right.
as well.
Right. Yeah. So they essentially are medically cleared, right? So you don't want to send somebody who's, suffering from, maybe acute, like an altered level of consciousness related to their liver, for example, to a psych facility, right? So we send them to an ER, they get medically stabilized, okay, or cleared. And then the hospital will then handle, coordination for transportation. Okay. And then if it applies, we try to connect them. I know it says housing resources, but we do our best. So every case is different, right? And so the resources we offer them must be pertinent to what they're currently experiencing. Okay. And we improve continuity of care, okay, especially for the high risk. We do this by good dispositions, good discharge teaching, right? But also we follow up with these clients, 2 to 3 days after. Okay, so we'll call and sometimes they'll still be at the hospital. Okay, and so we'll keep making attempts until we're actually able to speak with them or the family members. Okay, and I think a good follow-up, okay, is able to ensure the continuity of care for these particular clients. Okay, so how to refer, anybody can call the DMH access line. Sometimes we get calls that are referred from 988. Okay, anybody can call essentially. Okay, you're going to request a mental health evaluation, obviously, and then we need the exact location, the behavior that you're noticing, okay, and then a safety snapshot. So they're going to ask you questions, screening questions related to if there are any firearms, nearby, if they have any weapons, right? What is their current temperament? All right, are there any animals, dogs in the house, right? And that's pretty much what I have for you guys. One, make sure you're able to call early, okay? And even if it's not like a drastic crisis that you're seeing, okay, we can still go out. We can still go out and link these people up with resources, okay, and spend the time with them. Sometimes people just need someone to talk to, right? And so, we're available. So try to call early. And if you know anything about this particular person, okay, regarding their history, try to let us know. Okay. And then I'll also, like I mentioned, communicate anything that, might compromise, our safety. Okay. All right. Thank you very much. What I'll do is I'll have you guys talk with, Lauren. Lauren McHale is here. She's one of my colleagues. Okay. And she will tell you a little bit about Brain Health USA as an organization and how this might apply to the population that we see.
Click on React. No, just actual React. Hi, can you guys hear us?
Yeah, I can hear you.
We had a well, Matthew had a quick question. Thank you so much for presenting, by the way. It's super informational.
Yes, thank you so much, George. My name's Matthew. I'm a housing retention specialist. I think I heard you say that you guys bridge the gap for like after the shift is over for PMRT and is that correct?
Exactly. Yeah, maybe I didn't clarify earlier. Yeah. So
what are your hours of operation?
Perfect.
Then?
Thank you. That's a good question. So PMRT goes till about 5, 6 p.m. Okay. And then that's when we come in. So we start at 4, okay, and we go this is Monday through Friday. We go all the way until 8 a.m. the next day. Okay. And on the weekends, we cover all of PMRT. Okay, so weekends we're there 24 hours on Saturday and Sunday.
Okay. Thank you so much. That's very helpful.
Of course.
We had questions, a question in chat. What is your response time? And this is actually a very common question I always get about
Yeah.
the MCOT teams. And then if we submit a request, can we get an ETA on how long it'll take to respond?
Yeah, so our response times are comparable to what PMRT is doing. Okay, and you know, we've worked on efficiency, okay, and so we've been able to, you know, cut the response times down by, you know, a few minutes. But since we're a 4 p.m. team, we do experience a lot of traffic. But what we've done is we've managed to get a little creative with our scheduling and then which office they dispatch from so we can cut that time down. So as far as giving you an ETA, we do that as soon as we receive the call from DMH Access. Okay. So, and they're the ones that, you know, assign us the calls. And so as soon as we get that call, we give you a call, whoever requested the call, to give them an ETA.
Okay.
Okay.
Yeah, from my understanding,
Now,
it's still about
4 hours.
4 or 6 hours is the response time. Is that true?
Right. So, okay, so you're asking about when the call is placed till when we actually arrive?
Hmm.
Yeah. So, I can get you some numbers for that, but on average, yeah, it's about 3-4 hours. Yeah.
Hmm.
Yeah.
Yeah,
Some
I
days are
mean,
a little worse than others.
yeah. I guess that's the ultimate
Well, you know,
issue that we're seeing is that,
Yeah.
like if someone's experiencing acute crisis, it's, we kind of need some help, right away, right? So, like, are there
Mhm.
ways we can do what is there any way we can like work with you all? Like some of our cities are actually maybe even interested in contracting with someone like
Sure.
Brain Health
Yeah.
to reduce those response times and to have dedicated response in their cities. Is that something that you all would be open to?
You know, I can set you up with Lauren, and then she can talk to you about it further, and maybe we
Mhm.
can explore some type of, partnership. But just to go back to the response times. So we meet with DMH periodically, and that is one point of contention. Okay, is are the organizations that offer MCOT providing them with enough teams, providing the community with enough teams? So we essentially went on a hiring spree. Okay, and so we're substantially increasing the amount of teams that we have available, okay, which ultimately, will, result in, shorter
decreased time.
response times, right? Yeah.
Yeah.
So, you should see, at least in service area 8, you should see a quicker response time, okay, in about a month and a half, 2 months. Okay. I'm talking after 4 p.m. Now, what PMRT does, okay, is essentially on them. But again, if you also need me to communicate with PMRT directly, I also can. I can act as a conduit and, communicate some concerns, any concerns you might have. But yeah, we can definitely meet with you and discuss some other partnership for sure. Yeah.
Great.
Would like to add something to that too. Sometimes when we get the PMR team, when they send us the call from Access Line, the patient has already been waiting a while before we even receive the call. So by the time we receive the call, we do it right away. We call the patient right away and let them know if they're there. We go through our safety checks and we dispatch our team, which usually the time that they take is about between 45 minutes to an hour and a half. So that's actually from the time that we get the call and where our team is actually being dispatched to the patient home. So that's not really a long time. The reason why you guys have the recording of 3 to 4 hours is because these calls come in first to the access line, and by the time it's processed through the access line, and by the time we get the call, it takes that time. Once we get the call, our dispatching time is usually between 45 minutes to an hour and a half.
Yeah, this is an issue. So before this was born, even MCOT, we had conversations with the county, and the original model we wanted to do that we proposed was that the dispatch would actually come from our PD and for dispatch centers,
Okay.
local law enforcement. That was the model that would work for us. And then DMH went in another direction. And so yeah, and because of that, I guess that's causing some of these long dispatch times. So I wonder if we can even change that model to kind of go back to kind of the original idea of having a more wider range of dispatch options, I guess.
We can discuss other forms of ways. I just don't know if you guys, the thing is for DMH to pay us, we have to go through access line. This is how they pay us directly. If there's any other ways that we can do it to help your area or your community, we can definitely discuss this further and see how we can get the calls, because we don't get the calls directly. We have to get it through access line. And that's where sometimes patients does let us know, like, for example, if they have already the calls come in different colors, they're coming tiers. So depending on the emergency or how emergency is the call, by the time we get them, yes, they take some times being sitting there in the portal before we receive these calls. So if there's another way that we can get the calls sooner, then we can definitely send over the dispatchers or the team, the PET team, much quicker. But we don't have that option. We're kind of like stuck at that point. Also, we've noticed that there's a huge need to the family, because the mental health patient is not aware of what's really going on at that moment, because they're in crisis. So we try our best to create a support system for the families and the members. And many of these patients, believe it or not, can, coming from a medication management point of view, can be prevented because a lot of psychosis due to drugs and alcohol. And we have implemented some of the resources that we can do with these type of patients by doing injection prevention for psychosis, because a lot of the patients, the reason why they're not stable is because they did not, comply with the medication management. So a lot of the time, if we can incorporate some sort of, because many of these patients are coming through DMH, these patients already were in psychotic phase. They were stabilized at one point, and then they did not comply with the medication management or their pills. So I highly suggested that we do injection. There's a lot of good Abilify injections for these patients that we can maintain their stability, but for some reason they were not looking at that as a source of a resolution. So they said this is perhaps like we're forcing the patient to take injections, but we say it as a prevention, because these patients are not mentally stable. They need the help, and we need to support them. And if we can give them an injection once every 6 months, they will be a lot more stable. They're not gonna, we're not gonna use the city resources or the community. If we can implement, small certain things like that can a prevention for these patients, especially that this is our role. I mean, we've been in business for many years. Brain Health has been in business since 2004. We have over 250 providers. We see over 2,000 patients on a daily basis as a service that we provide for the community. We have all the highest insurance company in the community. So we know how to treat mental health patients. We know that due to COVID and social media, cyberbullying, we have the highest suicidal ideation. So many of our patients, they need a different type of help. And keep in mind, psychiatrists are not like your regular typical doctor where I have some objective data to rely on, like I have an x-ray to tell me this patient has a broken arm, or perhaps I have a blood test to tell me this patient is diabetic. We don't have anything like that. We rely heavily on subjective information from a mental unstable patient. So you have to understand how difficult it is, not just only to treat the patient, diagnose the patient, and figure out what's going on. And we rely heavily on the patient's family to tell us what's going on, because a lot of the time these patients are in crisis or they're in delusion, and we sometimes we can't, you can tell if this patient is under the drugs or influence or anything within that route. So we can try to help and support the family and the patient itself. So many of these could be secondary due to drugs and alcohol, the psychosis issues. So there's a lot of things that we can, provide value to the community, especially with homeless population, drug addiction, and also for, cases, bipolar cases that our patients are not stable. So we come in very handy, and because of our volume of doctors, we're able to see these patients within 24 hours to maintain stability. So that's basically what we do, and we've been very active in the community in creating that. And we do quite a bit of education as well for our team, because sometimes they get burned out dealing with mental health patients. So we work on our staff as well to make sure that they know how to deal with these type of patients.
Great, thank you for that. Do we have more questions from the conference room?
Hi, it's Matthew again. I just had like a scenario. So well, I guess I wanted to know like what you defined as acute crisis, right? Like, because like let's say we have a client that we've been dealing with that's unhoused and is constantly in an episode of schizophrenia, right? Refusing services, has been on the street forever. And based off of what you gave in your presentation, I would assume that he would be very highly, this program would work for him, right? Getting him connected, continuing this care with him.
Yeah.
Do you guys also, I guess, so yes, that would be, you're saying yes, that would be someone that we could call out.
Yeah, Matthew. Yeah. Go ahead.
And then do you guys also work with like, connecting them to like care court, stuff like that, documenting that to this new care court thing so that
No, Matthew, that is handled after they've been admitted to a hospital, okay? And they've been under the direct supervision of psychiatrists, right? And who's possibly maybe extended their hold or whatnot. But for us, we are a triage team. We get them, from unstable in a crisis, okay, to, these hospitals, okay? And then they will take it from there.
Okay.
Yeah.
But you do refer to like say ECM, right? Like will you guys take the time to do that?
We just started looking into this, okay, and doing ECM, and also we placed a high priority on initiating FSP for some patients. Okay. So yeah, I can't give you any data or information about ECM. Okay.
Okay, but you will refer to FSPs and
exactly.
Will you transport them to outpatient FSPs and
I believe FSP will have their own crisis team, right? And so that's always screened in the beginning of the call by the DMH operators. So we essentially get the clients that are not on FSP and are in FSP, but none of the providers are available to go see them.
Okay.
Yeah.
So I do have another follow-up question.
Sure.
So what if they're enrolled in home team, but home team can never make contact with them and they're continuing to have these issues, and we really are trying to get them connected to the care that they need? On top of also, I wanted to also follow up with you. I know you said you take them to the hospital, but the injectable thing, like what if it's just that person is unhoused and right now they just kind of need the injectable stuff because they're not going to be med compliant, and we need to stabilize them so that they can be receptive to receiving outreach services?
Yeah, definitely. We right now, if this person, no, if they're already like enrolled in the home team, that program, so are you saying that we would get a call from anybody that's involved in their care, the home team care, or are you talking about like if they're part of the home program and they're just not doing well and they're decompensating? Is that what you're saying?
What I'm saying is that like there's an outreach team that services the beach cities, and maybe the home team isn't coming out or says to us that they don't believe that person meets they're enrolled, but they're not like really providing, I guess, the services that are necessary for that person. And so,
right, Matthew, you just give us a call. Access, okay. You don't have to get into the details. Obviously, they'll probably request certain pieces of information from you, okay. But yeah, you just call us. Call access, and we'll get that call.
All right. Thank you so much.
Of course.
So I do want to touch up on what George was saying, Michael, is that it's not about putting someone on a hold, but it's more so getting the help that they need, either finding resources, writing a referral, finding, cooperating with everyone involved to get them the help that they need. Does that make sense?
Yeah, I mean, I think that's what we were looking for, is like not just the hold, but the kind of what happens after, right? The crisis.
So understand, our purpose is not to go into an environment where we just write a hold, right?
Mhm.
Our purpose is to go in there to make sure that the patient and the family get the resources that they need. If it is a recommendation to get placed on a hold, that's one of the options, but it's not the only option, right? The better you're going to be off, the better the patient's going to be off, is if we educate everyone in round, right? You're only as strong as the people around you. So educating the support system so that they can advocate for their families or friends will allow them to continue growth post hospitalization, right? Hospitals, I work inpatient too, right? Our goal is not to get the same patient over and over again. So what does that mean? We have to educate them so their goal is our goal. It's continuation after being hospitalized, right? It's maintaining safety post hospitalization, maintaining compliancy with medication, right? Maintaining if it's therapy, if it's FSP, whatever it may be, right? That's our goal, right? Our goal is not to get them back. Our goal is to make sure that they're safe and everyone's more informed so that they can fight for themselves after the day, right? That's our goal. We don't go into a situation and say, I heard what you're saying. I'm going to put you on a hold. No, it doesn't mean it doesn't. We want to create this rapport with the patient. We have to create this understanding with the patient so that when we're done interacting with them, they're going to continue this, right? That's our goal, right? Majority of ERs are filled with patients that are being seen for physical symptoms, but can be related to mental health symptoms, right? So if we actually address mental health and we educate and we teach and we learn about this, then we'll see less patients in the ED, which means the ED can, service people that actually need emergency situations, right? But it's all about getting to the point where not only are we called, but how can we service you? How can we help you in this acute moment to get you to the next part of life?
Yeah,
right?
absolutely. Yeah, thank you, Brad.
So,
Yeah,
what George was saying about secret weapons and relatability. So I was a psych patient at 12 and 24. So when I go into the community, I don't go in there as a clinician to not listen to anyone. I go in there with this understanding that hospitalization does help. Medication management does help. And some people don't like that idea, right? And so our job is to kind of convince them that how useful it can be, right? We have to build rapport within an hour. So you're telling me you have to trust me in an hour. So how can we do that if we're not relating to the patient themselves, right? So when we ask these things about like long acting injectables, when we talk about hospitalization, FSP, other referrals that we can do, at the end of the day, we're setting you up for success post hospitalization if hospitalization is needed, right? If hospitalization is not needed, then let me set you up so that you're more informed, you have the more resources to make sure you don't have to go to a hospital, because I do know what it feels like. I do know how cold it can be because of being in a situation that's brand new, right? Today,
all right, Bradley,
mental
I
health
think
has
we'll have
been
to leave it there. Yeah, we have another speaker coming
no
on,
worries.
but no, I think what you're saying is resonating. I think I know for me and as well as our case managers. And so yeah, we love to maybe continue the conversation offline on how we can more closely work with brain health. Maybe trying to get those response times down. I do know we have that need off the off hours that you guys work in, so that's
Yeah.
great.
Yeah.
So yeah, but so thanks, Bradley, George, Lorene. Thank you for coming. Really appreciate it.
Thank you, everyone.
And yeah, let's
Pleasure.
continue talking.
Thank you.
Yeah. Great. All right. Well, moving on, we have another presenter on um, mental health, mental health first aid presentation from Providence, and this is Lucia Flores, community health supervisor.
Yes. Hi, Ronson. Hi, everyone.
Mhm.
Thank you for giving us this time to kind of explain a little bit about what we do. So my name is Lucia Flores, and before I kind of share my presentation with you all, just a quick question. How many of you, I ask a lot of questions, so play along with me, please. How many of you have heard of mental health first aid before? How many of you have not heard of mental health? So there, okay, so I see some responses for both. So that's really kind of why I'm here to kind of expose you to what mental health first aid is. So let me go ahead and get this started. Okay. So again, my goal here today in these few minutes that I have is to really have everybody who's in attendance today walk away with what mental health first aid is in order for you to sign up in the future, to have your teams, family members, friends, community residents. Just know that every resource that we offer is at no cost. So this is one of the services that we offer. And I do want to take a couple of moments just to explain who we are in case you're not familiar. So we are with the Providence Health System. However, we're under this department that, although we are under the umbrella of a hospital setting, we work very differently and separately than the hospital. So we have two wellness centers, one in Lawndale that we have in partnership with Lawndale Elementary School District. That one's been open almost 2 years. And we also have one that's been open since 2014 in Wilmington, California, right next to Hawaiian Avenue Elementary School. All of the services that we offer it can be offered here in these two centers. They really are community hubs, but we offer all of our health education classes all over the South Bay area. And then here are a couple of things that we have. We facilitate as supervisor of our health education programs. We have our nutrition class, so we have a participant here. We partner with the LA Regional Food Bank. They get food boxes. In the middle picture is our Gold Diabetes Management class, so we offer those classes as well. On the right, we have Monique there, who does outreach all over the community. So we really are here for the community. And like, as I mentioned, even though we're under a hospital setting, we don't ask questions as to what health insurance you have, are you a patient? It's just really is for the community. Do you want to learn more? Do you need assistance with CalFresh, Medi-Cal enrollment, immunizations? We have group exercise workshops. They are all open to the community, again, at no cost. And so to kind of jump into this mental health first aid training, this is just some numbers that I wanted to kind of just share as to how it relates to this training. We, as all of you are providers, know how prevalent mental health challenges can be in our communities. And one of the things that we cover in this training is we talk a little bit about barriers. Is why don't people reach out to get services? And there are many reasons why. And we even say, even if every single person who was experiencing a crisis or a challenge wanted to receive mental health treatment, there just aren't enough health professionals, let alone health professionals who speak the language, who understand the backgrounds, the cultures of our community residents. And so that's kind of really one of the reasons why I truly believe in this training and how it can be helpful, not just to us as, providers in the area, but to every single community resident. This training is to empower everybody to help one another. And so for my next questions here, what would you do? So just to kind of get you thinking about this. So what are we told, or what do we know? What do we do when we are walking down the street or at any location and a person is experiencing or having what we think is a heart attack? What are we taught to do or told to do?
CPR?
CPR. What if we don't know CPR?
Call 911.
Call 911. What about someone fainting? Pretty much the same thing, right? CPR, we know, call 911. And then when we ask community residents, what about when someone is having a panic attack? What's the first thing that we can do? What about when they're showing signs of a substance use? And that's usually kind of what we get, so there's a lot of reasons why people hesitate, especially in our community, because, it could be the stigma. They just don't know. I was raised to not talk about mental health, so it's just, we're not really taught. And that's the beauty of this training. This is really where these trained mental health first aiders come in. So what is mental health first aid? So it is a training. It is a skill-based training. So throughout the training, whether it be in person or virtually, we do group activities, we do scenarios, we watch videos. So we really want participants to walk away empowered, walk away with applicable tools that can be used in the real world, not just at work, but with their family members, with friends, with, at any location where they might be. It really creates a new path of resilience and well-being. So it helps people kind of think about mental health in general in a different way. That there is recovery, just like when we talk about physical conditions, we do things to help the person recover. So can we use the same or similar tools to kind of create this path of resilience and recovery. It's to reduce stigma and discrimination, to improve overall psychological safety, and really to address those mental health and substance use challenges and to kind of fill in the gaps from those kind of numbers and data that we saw there. Again, at any point, if I didn't say this already, if you have any questions, please feel free to interrupt here. And so where can this training help? So as I was hearing the other presenters, so a lot of the services that are offered are usually kind of after the fact, or a lot of people are not aware. One of the things that we do during this training at the end when we talk about resources, we like to give our community members, our trainees, resources that are available. So I know some of them that I heard today will be added to this resource list for them to be aware. But this training is really just to provide that early intervention, right? We don't take a CPR class with the expectation to know that how to do open heart surgery if needed. We're taking that training to kind of give us the tools to know to intervene as soon as possible and then connect that person to professional help. And the same thing is with this training is we give trainees the tools, what to say, who to connect to, when to connect to, how to recognize signs and symptoms to then be able to help these individuals navigate to any other resources if needed. Okay. And so there are two types of mental health first aid trainings that we offer. We offer the adult and youth mental health first aid. Now, one thing I forgot to mention in the beginning with the what is this training has been around since 2001. And it's been, it's really a worldwide thing. It actually started in Australia, but every country kind of has adapted the training to meet its individual needs. And so really both of them are very similar. The really main difference is that the adult mental health first aid, it trains individuals how to recognize those signs and symptoms in other adults. And then those that take the youth mental health first aid, we cover the same steps that I'll show next, but it really is to help with youth ages. You hear 10 to 18, 12 to 18. It's usually 12 to 18, but we're noticing a lot of these mental health signs and symptoms are showing up as young as 10 and even younger. So it really doesn't matter what training one takes, but just make note that some of the scenarios, the videos are different depending on whether one is being trained in the adult mental health first aid or the youth mental health first aid. And so what do participants learn? So this is one image that participants are going to take away. They're always going to see it. So we talk about risk factors and warning signs of mental health and substance use challenges. We give information and they get information on depression, anxiety, trauma, psychosis, and substance use. And then usually when people think about mental health, a lot of our trainees, community residents that don't have a mental health background, they tend to associate mental health with these with the farther end of the spectrum, right? The psychosis, the extreme trauma. But we want them to know that mental health can, that's what I tell them is if we have, just like we have organs, there's always going to be some physical health ailment related to it. If we all have a brain, there's one point or another, we're going to have some mental health related challenges to it. So a lot of it is they don't necessarily need to go into the ER or inpatient or have some outpatient. A lot of these times is people are just having a hard time and they just need somebody to empathize, to understand, and to provide hope. And that's really what this training is about. So this algae plan it's a 5-step action plan that's taught in both youth and adult mental health first aid. And it really empowers individuals to not be afraid of helping others when they're having a difficult time. It helps people realize that it's okay to go through difficult times. It's okay to have a conversation. It's okay to ask the question, because we talk about suicide prevention in the training. So through scenarios, through videos, through group activities, we kind of learn how to use these steps in different scenarios. Just kind of like with CPR, how you have the steps, very similar with this mental health first aid. And so to just kind of give you a brief overview of how one becomes a mental health first aider, I put it at the bottom, but I should have put it at the top. This training is for everybody. We've trained people from across all professional realms to parents. These are a group of parents that we trained in Lawndale. So, we've trained when you call 211, the operators, we've trained, all kinds, teachers, social work interns, the clinicians, because really what it does is that it really makes the information in a way that's understandable, not scary, and allows you to really use it in real life scenarios to just help someone who's going through a mental health challenge, and then to connect them to resources if they require a little bit more. So really what it is you sign up. If you're interested in bringing this training to your teams, family members, you just kind of send me an email. We will help you create an account on Mental Health First Aid Connect. There's 2 hours of self-paced pre-work, whether it's in person or online. So it's very self-paced. It just kind of gives you the general background about mental health first aid. Then there is the training. It can be virtually. We've done it in person. It's 6 to 8 hours, depending on the setup. We've worked with some organizations where we split it in 2 days. There's been sometimes with parents, because they can't do a full day because, they drop off their kids and pick them up. So we'll do 2 hours for 3 days. So we really work with people because our goal is to just have them trained, give them this information. Then after they're done with the training, they kind of go back, complete a post-evaluation, and then everyone receives a 3-year certification from the National Council for Mental Wellbeing. Just like kind of when you complete CPR and you get your CPR certification, very similar concept here. And also be aware that we offer these trainings in English and Spanish as well. And just if I haven't shared enough as to how important or how valuable this training is, as far as impact go, we're able to support those in need. We're able to reduce mental health stigma. That's a thing in our communities that I've seen. We've facilitated this training since 2019, and that's really what the biggest change that we see in our trainees, that they may not be able to, as even as I was hearing some other presenters, there's a lot of information that's new to me, and I've been in the public health field for over 10 years. But it really, just how we tell our trainees, just by thinking about mental health differently, we are able to help those people so much more, because now they're not afraid to be patient with the individual. They're not afraid to ask, how they're feeling. They're not afraid to connect them to resources or have them take the medication or have them attend counseling, because they think about mental health differently. And I think from facilitating this training, that's really the biggest impact that I see in our trainees. Being a mental health advocate, I tell trainees it's not necessarily you applying the algae steps in a scenario, but it can be talking about the family. We don't think about the impact that mental health has on the family members. I've been in situations where I have to explain to family members about another family member so that they can understand, and I can educate them about the mental health process in our communities. And then more than anything, building a community, just like I've done here. I've been presenting in a lot of these kinds of meetings, and I've been able to kind of network with a lot of people and resources and organizations that I can then offer to our trainees so that they're aware of what services are in their local communities. And then I'll just kind of finish off with these. Their quote, so we do like to follow up with our trainees to kind of know how the training has helped, if it has helped. Like I said, because we've trained all kinds of people. We've heard cases of them helping their children. We've heard stories of teachers being able to help their students. As a previous teacher, this training would have been invaluable to me had I received this training. So it is something that we want to continue doing. With that being said, I highly encourage, if you know this is the time to do it, because some organizations do charge for this training and we don't. It's because we do receive a lot of grants from the federal government. But as we've seen, this current administration is not very fond of mental health resources. Our grant was actually taken away and then it was given back to us. So we really want to fit in as many trainings as possible to be able to kind of train as many people as possible by the end of this year. But we really, because of the impact that we see that this training has done, we do want to continue offering these trainings at no cost to everyone. And then just kind of some upcoming trainings. My team and I just kind of scheduled some there. So there's no flyer yet because this just happened yesterday. We invite people they can either attend these trainings that are already kind of like set on our schedule, or depending on your organization's needs, we can schedule on another day. We can, like, as I mentioned, it can be flexible, it can be 2 days, 3 days, whatever works best for your organization. And trainings, as far as capacity, is as a minimum 5 participants in order for Mental Health First Aid Connect to kind of accept the training, all the way to a maximum of 30 participants per training. Okay. And with that, I end the information today. Again, I want to thank you for giving us that time to share. Here's another picture of one of our other groups at our Wilmington Wellness Center. And if you have any questions, please feel free to email me and I'll help out as best as I can.
Great. Thank you, Lucia. That was wonderful. I've done a variation of this training with the sheriff's office, and I learned so much. I think one of the important things that you'll need this is at Connect Days, because sometimes what happens is, with a lot of people around, it might be triggering for folks, and they might experience a mental health event. And I've learned, like, unlike in heart attack, if someone is having a mental health episode, time is on your side. You don't necessarily have to rush things, and having that patience is very important. So it's just training like that is very important. And we have our Connect Day coming up, so hopefully we won't have to use our mental health first aid training. But if something happens, we would be prepared. Addie, Grace, do you know is this something that we may want to do, like to host one of these trainings at one of our meetings? Maybe I know it's 6 to 8 hours, but it
Yeah,
might
I'm
not be a bad
early.
idea.
Am I on mute? Oh, no, I think it's good. I can't tell because I
Yeah,
can't
yeah,
see.
we can hear
I
you.
think,
Okay, yes. I was like, I can't tell if we can see it. Apologies, it's okay. Yes, Marley and Matthew and I were just discussing how it would probably be helpful, and obviously we would be open to hosting it here at the COG since we have the space for it. So I can get together with Grace to see if it's something that we can coordinate.
Absolutely. And Ronson, I just want to let you know, I went through the training at the DMH offices I think I did get a certificate. Sorry, Lucia, I did get a certificate. But our goal was, after leaving that, I was going to connect with you guys about training, the new people we get involved in homelessness, whether they're, faith organizations or nonprofits that want to get more involved, but they don't know much about working with the homeless population. So definitely I'll touch base with Addie to see if we can schedule that in the next quarter.
Great. Well, thank you, Lucia, for your time. We're running a little bit tight on time, so we're going to move on. And if anyone has any questions, we'll send out the PowerPoint with her contact information, and so you can just reach out. All right, so then moving on, LSF and La Casa updates from the staff.
No updates for LSF at this time, but I know that La Casa has some small updates, so I'm not sure if Kevin is on right now.
Yeah, I'm on here. I can give those updates quickly. Hi, everyone. It seems like there's a lot of new faces, so it's great to see a big meeting. For those who don't know me, my name is Kevin Umani. I'm the housing project coordinator here with the COG. Because there's a couple of new folks here, the COG is an eligible jurisdiction that receives funding from La Casa, and La Casa is the Los Angeles County Affordable Housing Solutions Agency. New agency started 3-4 years ago with the help of state legislation and Measure A. And we implement various programs, and I'll start with one of them. We get funding to implement affordable housing production, preservation, and ownership programs. And La Casa has some of their own funds for these programs. And over the next 2 months, the La Casa board will be approving $240 million in capital deployment funds for affordable housing in LA County. In fact, at today's board meeting, the board approved $100 million for 10 projects across the county. And to put that into perspective, 10 projects, that's 566 new apartments, 900 people housed, 383,000 square feet of construction, 958 new jobs. And then next month, the board will be approving an additional $140 million for several more projects. So, it's exciting times. And while not totally unrelated, I also wanted to mention that, the city of Los Angeles will also be deploying $340 million worth of funds across 80 projects in the city. So, with La Casa and the city of Los Angeles, we're seeing over $500 million of investments in affordable housing. And it's truly in an unprecedented time in the county where, in 18 to 24 months, we're going to be having more housing than we ever had, or be building more housing than we ever have. So exciting times. So, and then another update quickly, the COG also is mandated to implement renter protection and homeless prevention programs. So I wanted to quickly share my screen. Let's see.
And I put the website on the chat. This is the entry point for folks who need rental assistance or any other types of financial assistance.
Yeah.
And
So I was
Kevin already
gonna-
did the presentation last month, or the last time we did this, and so we won't get into that as much. But
Yeah.
go ahead,
I just
Kevin.
want to quickly, yes, thank you, Ronson, for putting that in the chat. So if you go ahead and visit that, the COG has a emergency rental and financial flexible assistance program. And if you visit the website, it has some information about what the program is, what it's intended to do, some of the eligibility criteria. And then like Ronson mentioned, I presented it at the last meeting, so I won't get too much into it. It also talks about the documentation required for folks to receive assistance. And then I guess the most important part will be, if you're in the South Bay, where should you go seek assistance? And if here we have a chart here, and if you're in the following cities, Inglewood, Lawndale, Hawthorne, you will visit the following website with St. Margaret's Center, one of our great service providers. And if you're in the city of Torrance, Gardena, Carson, Lomita, you'll go to the Watts Labor Community Action Committee's website. And in fact, we also partnered with the city of Gardena because they have an existing rental assistance program. So they have an existing infrastructure that we're going to be supporting. So soon you also see a city of Gardena here where Gardena will be moved from WOCAC to its own table here for Gardena. So we were the first eligible jurisdiction to launch this program in November, thanks to our great partners here at SMC and WLCAC. And to this day, that is still the case, but La Casa has some of their own funding. And I won't go into this whole presentation. I will send this out, but La Casa is partnering with 9 service providers to provide these services countywide. You can see some familiar organizations here. In this presentation, it'll detail some of their services proposed, and also the geographic area that they're serving. I won't go into depth, but it's good information because now that these resources aren't only in the South Bay now, they're going countywide. So we'll make sure to send that out now. They have 9 awardees. About 5 of them already have marketing materials on their website. So those are the updates from me, and we'll make sure to send this information out to you all.
Great. Thanks, Kevin. So then just moving on to legislative updates. I think I saw Janet Turner. Any updates from you? Oh, it's very quiet, Janet.
Oh,
Please.
we're still waiting to hear about the road to housing, the that has to be rectified with the House version called the 21st century. It's going to be the first bill in a long time that actually takes some steps to help encourage affordable housing. So looking forward to them finally getting that reconciliation done. And also hoping to finally get the full budget finished and approved, so I can give you some specific updates on appropriations that have been given to HUD for housing. Okay.
Great. Thank you, Janet. Any other legislative offices that would want to provide an update? Going once?
I
Oh,
want to provide an
Moises.
update.
Great. Thank
Oh,
you.
and you also have Moises. Why don't you go first?
Yeah.
I defer to ladies first, then I'll be next.
Oh, you want me to go first? Okay.
Yes.
The COG is very interested in we're actually sponsoring and running a bill with Senator Ben Allen, SB 799. And what it does is it's cleanup legislation for our regional housing trust. When the trust was created in legislation, it had funny things in there about who appoints the board members so it's cleanup, a lot of detailed things that are just administrative. But the one thing we wanted to add to it is the ability for our trust to be able to do workforce housing. And we've asked Senator Allen to add that into the bill because the way the trust was formed, it specifically does not say we can do workforce housing. And so we would like to have that added. We could use your letters of support. If you see Senator Allen, we'd like him to add it. And also any of our legislators like Assemblyman Gibson, we'd like you to advocate for it. It is in the Assembly. It's SB 799. And if we can get the words workforce housing into the legislation, it would allow us to do what other trusts can do. And for some reason, it was specifically left out of our enabling legislation. So if anybody who has any questions or wants further information, they should contact me because this is really a priority issue with us. Thank you.
Yeah, and then just really quickly, the two kind of homeless and housing related bills we're supporting coming out of our steering committee. One is the one that will allow cities to better access HAP funding. We're supporting that bill. I'm sorry, I don't know the numbers off the top of my head, the bill numbers. And then the other one, which is the new bond that's being proposed that voters will vote on. We're supportive of allowing voters to vote on it, but the bond would provide more affordable housing dollars statewide.
Ronson,
Yeah.
I have the bills in front of me, but
Okay.
I have to say that that was the steering committee, and the board hasn't actually voted on them yet.
Oh, you're right. You're right. So it has to go through the board. So
Just to go
my
through the board.
apologies. I'm jumping the gun a little bit. Yeah. All right, Moises.
Sure, thank you, Ransom. Of course, our office here at State Assemblyman Mike Gibson, just last month, we've actually provided some services to all constituents, from the expungement to free tax clinic prep. And also, this past Saturday, we've actually done our 5K walk and run at the Wilmington waterfront, where we had thousands of participants participating at the 5K walk and run autism awareness. So our next event that our office is hosting is Voices of Hope, Compton Marches for Immigration Rights. Basically, this will be the third march that Assemblyman Gibson is conducting. And of course, it's a time to uplift and heal, honoring immigrant families and workers affected by the deportation. And hopefully, everyone here can join us and stand with us in solidarity for peace and unity. It would be on Friday, April 24th, 2026, from 5:30 to 8 p.m. We would be gathering at the Sacred Heart Catholic Church, address 1720 North Culver Avenue in Compton. And the vigil will be at in the corner of Fig and Oleander Park at North Oleander Avenue and West Fig in Compton. And that's pretty much my report from there. I do have my counterpart from the office of Congresswoman Annie Chin also in here too. And that concludes my report and any of the events going on. Thank you for your time.
You're muted, Ronson.
Is Baragon's office here? I don't know if I see the rep. But all right, we can move on if there's no other legislative updates. Next up we have Jackie, you did the updates, right, for the COG? Or do you have
So
more?
the major update for the COG is that on April 30th, which is going to be in a week and a half or 2 weeks or something, we're having our very first meeting of the South Bay Regional Housing Trust. That is a different organization than the COG. It will have a different board of directors, and they have all been chosen. And so at that first meeting, it's pretty much an organizing meeting. But if you're interested in what this new agency will be doing, for the first several meetings, we're going to be doing study sessions so that we can understand what a trust does, what our JPA allows us to do, what programs and opportunities we have through La Casa and other agencies, and it's going to be a real learning opportunity. So those are public Brown Act meetings, and I can tell you that the first one is at 4 o'clock on April 30th. I cannot tell you any more because the board is going to vote on their regular meeting date and time. So we'll know that after April 30th. If you're interested, there will be a trust website. It's the South Bay Regional Housing Trust. So we're very excited about it, and hope that all that money that Kevin talked about will come our way so that we can also do housing. I think that's, I don't know if there's anything else that I need to talk about.
Our General Assembly went really well.
Yeah, I hope that some of you were at our General Assembly. We were very excited about it. It did go really well, and now we're looking for topics for next year's General Assembly. And the one thing about our General Assemblies, before you flood me with topics about homeless and housing, is that we want to have something that's no one else is talking about, and specifically to the South Bay. So we want to have something unique to us. I'm just looking to see if there's anything else that I wanted to tell you about the housing. Oh, at our board meeting, which is this coming April 23rd, so it's next Thursday, we're going to have the colonel from the LA Air Force Base come and talk about the happenings. It's very, very busy there. What's going on at the LA Air Force Base and how it feeds into the fact one of the reasons why we're actually talking about amendments to SB 799, our bill for workforce housing, is the Air Force Base specifically has workforce housing as an issue that's extremely important to them, and the fact that we need more in the South Bay. I don't think there's anything else. I will let you go.
Yeah, and April 30th, historic meeting, the first ever meeting of the South Bay Regional Housing Trust. And then thanks to Jackie for 3 months. She was spending her Tuesday nights at city council meetings, getting our cities to join. And
With Ronson.
yeah, I would have got 4 cities, Jackie, but you got 11. So our brave and fearless leader, Jackie, was able to help create this wonderful new agency that will help people experiencing homelessness find housing here in the South Bay. Next up, we have one of our favorite LA County staff members and also constituent of the South Bay, Clifton Trotter.
Thank you for the lovely introduction, Ronson. I'll be quick. I want to do an update responding to the response regional plan. So I'm going to share my screen here. Hopefully folks can see that. Can you guys see that?
Mhm.
Okay, excellent. Let me close here. What did I just do? Hold on, give me just a second. I did something I didn't want to do. I'm going to stop sharing because I cannot see my presentation.
We saw it.
You saw it, but I didn't see it. Now I see it. Are we good? We here?
Yeah.
Okay, excellent. So, as stated, I want to talk a little bit about the responsive regional plan inventory. This is a public tool essentially used to really collect comprehensive data related to the activities that are going on throughout the region from various jurisdictions. Slide. I won't give an overview of the responsive regional plan. As you might already know, the regional plan was approved by ECRA. The real focus is really to provide a singular framework, a sort of singular plan, if you will, to really combat homelessness and really address transparency and accountability. I think this tool serves as a vehicle to really support the regional plan. So what is the responsive regional plan inventory? Essentially, it's an inventory of programs and projects led by public entities that aim to address homelessness and improve housing affordability throughout LA County. So essentially, the tool itself really captures the projects that are being sourced from different entities, whether it's the city, Council of Governments, Continuums of Care, LA County departments, and other public entities such as unincorporated areas, La Casa, Metro, and what have you. So how is that data supplied? The data is simply populated through various sources, one being Measure A funded local solutions fund scopes of work. So when we work with jurisdictions and advise in terms of homeless programming, we're able to collect their programs and projects going forward for the fiscal year. That information is populated and used within the inventory tool, as well as information sourced from LA County's HAP. So that's the Homeless Housing Assisting and Prevention application. That information is also utilized. And then lastly, more information from various county departments and also to program information from the different public entities. What does the outreach ultimately look like? So outreach to the regional partners and local jurisdictions continues, and additional data is forthcoming. So this is a very continuous and ongoing process. Data will be added or updated in the response regional plan as it is received and reviewed. There will be ongoing refinements to the data in the inventory. So again, this is really about continuous data being updated and refined for greater accountability and ultimately system refinement. With that being said, the responsive regional plan is really a living document. It gives us the ability to align and leverage collective efforts of regional partners serving the homeless service delivery system countywide. So again, we're able to utilize, integrate, and synthesize the data from across the region for better system refinement. Data fields collected in the inventory. This really just gives an account of the data fields that you will see within the inventory system. One is impact category. This really looks at the major buckets in homelessness, so interim housing, permanent supportive housing, mental health services, what have you. The action items really just collects the programs and the projects. The other identifying markers, regional partner, jurisdiction, in terms of accountability and understanding the direction of where we're going, what's being captured in data fields is the Measure A goals, and also to the metrics, so really measuring our performance. And then we have funding sources, special populations, data systems, number of units, lots of beds. This is allowing us to really follow the flow of funds and really quantifying, how those funds are being used, and then unit type. What's important to know is that when you actually go into the inventory, you may see some blank fields. The reason for that being is that, some of the fields might not apply, might not be applicable to a particular action item or impact category, or maybe that information just hasn't been submitted yet. So if you see a blank field, don't think that in some situation that the inventory system is incomplete and it's not operating as it's supposed to. It's just some simple issues, if you will. What the inventory actually looks like is right here before you. This is a screenshot, as I just previously stated. If you look at the top row, you'll see the data fields. First, the impact categories, the action item, the jurisdiction, the Measure A goals, the metrics, funding sources, and so forth. Airtable is the program that we utilize in order to capture the data, in order to synthesize the data, run reports. And so you'll be able to, if you haven't already, get a chance to kind of play with Airtable and get a sense of the inventory. So how do you update the responsive regional plan inventory? Pretty simple. Regional partners that are ready to submit data into the RRP can do so in two ways. One, those with 10 action items or less can submit into the developed online RRP submission form. Those with 11 action items or more will utilize the template Excel that facilitates large data submission. So if you have action items, 10 items or less, there's an online submission form that you can utilize. We'll talk about that a little bit later. 11 action items or more, there's an Excel template that can be utilized to do that. In terms of updating existing items, regional partners can also edit data currently found in the RRP to correct entries and or update their information through the methods highlighted above. So updating existing methods is the same sort of methodology that I discussed. You would either use the online submission form or you would use the Excel template. Guides for how to submit and update RRP data have been developed to support regional partners and ease the submission and update process. So if you need guidance, you can reach out to myself and also to my colleague, Marco Santana. We can direct you to make sure that you get those guides if you need those instructions. Additionally, if a regional partner would like to add or update information to the RRP, you can email rrp@hsh.lacounty.gov. And any matters related to the local solutions fund, again, reach out to me. I'm the representative for the South Bay City COG and also to District 2 and 4. For any related items to Districts 1, 3, and 5, reach out to my colleague, Marco Santana. In terms of the online submission form, here's a screenshot of the form. As mentioned, same sort of data fields that we saw earlier. You have full name, date, work title, work email, phone number, the jurisdiction that's providing the submission, the action item. You'll, identify your programs, select the Measure A metrics, the goals, what's the funding source, the special population, the data system, and what have you. And again, the submission form online is for 10 action items or less, but it's pretty self-explanatory. And that concludes the update on the responsive regional plan inventory. I'm here for questions. I also have my colleague from funding and allocation, Norma, who's intimately familiar with the responsive regional plan inventory, and we're able to answer questions if you have any.
Great, thanks, Clifton. And so everyone can definitely see some of our metrics online using this tool. And if you have any questions, feel free to also reach out to my team, Addie and Maroli, who are responsible for our LSF implementation. All right, with that, we can open it up to the group. If there's any other updates, yeah. Hey, Paige.
This is Paige Kalojetovich. I did have a question for Clifton, actually. So I guess my question is, how are you outreaching to cities to make sure that this gets populated appropriately? I mean, I know we get the emails, but I think it's important that it is complete because it is a tool for us. So how are you making sure that that happens?
Yeah, so what we do as really part of our technical assistance related to Local Solutions Fund, we host quarterly implementation check-ins. And in these quarterly implementation check-ins, we review quarterly reports that are completed by our local jurisdictions. And so as part of that work is really on the back end, is us really sort of solidifying that the data that's being presented is precise and accurate. And so we have these ongoing conversations with the jurisdictions to make sure that we're getting updated information. And we also, too, sort of do a cross-reference or walkthrough of the quarterly reporting submissions and to sort of do a cross-check with the inventory tool. So there is some additional back-end work to ensure the accuracy of the information.
Okay, thank you. Yeah, I'll continue to advocate for cities to do this, but I think it's going to take more than just, us, I guess, asking that we get it from the cities because this tool will be irrelevant if it's not complete. If we just have local solutions and county funded programs, it does not paint the picture of what's actually happening as it pertains to programs throughout the county, and it's not a useful tool then. So, however, I can help do that, but I do think we need to do more outreach to cities to make sure that it gets done.
I think you're right. And I think part of the thinking is that this is a living document. And so it's going to be open to revisions and updates. And I think if it means that there needs to be greater, more intentional outreach to jurisdictions within the county, I think that's something that will be investigated and probably eventually implemented.
Great point,
Great,
Paige.
thank you.
Yeah, a lot of our cities are doing even more work outside of Local Solutions Fund, and so yeah, it's important to capture all that information. All right, so yeah, opening it up to anyone else with any updates. All right, anything we're missing? If not, then pardon? Oh, Addie?
Nothing. I think that's it. We're at time.
Okay, great. Well, thanks everyone for joining us, and hope to see you all in our next meeting, which is I think what's the coalition meeting is
May 20th.
May
Good,
20th.
good news. May 20th, and you guys are hosting Ronson. It's going to be at the COG offices.
Oh, awesome. Yay. Well, hope to see everyone there in person. That'd be great.
Great.
Okay. Well, thanks everyone. Have a good, wonderful evening and rest of your week.
Thank you, everyone.
Thank you.
Good afternoon, everyone.
Au revoir, mon amis.
Oh my God.
Ciao for now.
My butt hurt. Oh, wait, are you?